The next session would be on recent advances in kidney failure. I would invite Dr. Lalit Pursnani, Professor Nephrology, Dr. Saurabh Srivastava, Professor Medicine, Dr. Amitesh Aggarwal, Professor Medicine, and Dr. Ashok Grover, Senior Consultant Medicine, as chairpersons for the next talk.
So I have the pleasure of inviting Dr. Sanjeev Jausja, who is a senior consultant nephrologist at Indraprastha Apollo Hospital and is also serving as academic coordinator for the Department of Nephrology at the Apollo Hospital, New Delhi. Over to you, sir.
Thank you. Good evening, everybody. In fact, I must say I'm thankful to the organizer, particularly Dr. Nehru, for this invite. And my talk has been made much easier by my two predecessors who just talked about it, Professor Vijay Kher and Professor Chhabra. Another incidental point is that we all three belong to same alma mater from Amritsar Medical College, surprisingly maybe a Dr. Chogi effect. So that must be intriguing most of the physicians from college to get into the nephrology field. I've been asked to speak about the recent advances in the kidney transplantation, but since the advent of the transplant, quite a few things which has just been talked about by Professor Chhabra also, ever since this first transplantation happened in 1954, and between these two monozygotic twins, and the Indian first transplant which happened sometime in the year 1971 at CMC Vellore, which has been alluded to already by Professor Chhabra. Since then, there is a newer and newer advances which has been coming up. No nephrologist or a physician or a transplanter could ever say that he's probably perfected the art of transplantation. The newer and newer things would keep cropping in every now and then you have to ratify your practice trends, outcomes, and you have to overcome all the barriers which keep coming across this. So I would just take you through the journey, how the transplant has evolved in the last about 50 years. But before we go through that, I would just try to share some amount of the epidemiology of the kidney disease, particularly the end-stage kidney disease. What is the quantum of disease process which would warrant the patients who should be given the supportive treatment strategies in the form of transplantation or the dialysis. All these are the slides which I had been presenting for the years in different kind of talks, but all have one common understanding. Since in India NCDs do not have any kind of a statute to mandate that, it doesn't mandate us that we should make any kind of a registry, so we don't have any data. All the data which we have about kidney disease, whether the all stages of kidney disease or end stage kidney disease, is all has been alluded to, which has been referred from Western world where Indian population is living, or we have done a small patchy studies from where we have evolved this. And what we have evolved is the incidence rate of end stage kidney disease, which is to the tune of about 250 per million population. Now since we are about 1400 million population, on an average you can say about 350,000 new patients in every year are there who are looking for the transplant or the dialysis support system if they are eligible for that. And at the same time, if you accommodate the previous year's existing patients, the load goes up to the which is called as a prevalence of end-stage kidney disease, varies to the tune about 800. Now I'll put another figure about 50 to 800. I'm sure anybody who's epidemiologist who has got interest in epidemiology is going to ask why the number 50 is being referred when the incidence of a disease is 250. It's a bit of a mind-scratching fact. Ironically, our patients do not live a calendar year. So it's possible that we have an incident numbers which may be higher than a prevalent patient. So this is a very unique condition, because CKD we don't have that kind of a catering abilities that we could cater to all of these patients who had become end stage kidney disease. They could live on to the next calendar year. So that's why our even this number of 50 could also be a true number. But since these are all extrapolated numbers, so they can't be dogmatically stated around them. Now look at the irony of the situation. last year we did 16, this is the data from the Government of India, 16,000 transplants. That puts us on the global map as the third number country doing the kidney transplantations. Number 1 is America, number 2 is China, and number 3 is India. Now 16,000, now that amounts to roughly about 9 transplants per million population. And if you look at the CAPD insertions, about 4 per million population. And at the best, hemodialysis initiated by patients maybe about 20 or 30. So if you put all these patients together, the number is only 30 per million population. That means 220 patients are left with no options to get themselves treated, whether it's an end stage, whether dialysis or a transplantation. So we are nowhere close to giving them the requisite amount of treatment which they are looking for. That's why what Professor K just a few minutes back talked about it. As a physician, our major responsibility is to understand the patients who are vulnerable to develop end-stage kidney disease and to give them a treatment strategies or at least the advices which could be preventable. But in larger interest, with a country where the potable water is a problem, I don't know how the prevention strategies can be rolled out to the masses. Very, very difficult thing to state. But the things which we can do is capacity building. We can definitely increase our capacity by increasing the skill manpower, by improving the financial status, which of course these are the few changes which would come over the years of time, and it is apparently coming in the society. Then the important fact which most of the nephrologists would agree who have been practicing in the last 2 decades, we have seen there's a serious change in cadaver transplantation program in India. I mean, it's taking off, though it's in a very, very early stages. It's in an infancy stage, I would say. But the program has been rolled out at a pan-India level, and hopefully in, I think, next decade, if I continue to practice that point of time, I feel there would be a decent amount of cadaver program in the countries. Then there are other things which we can tweak at my level, at the practicing level. We can tweak at few facts, like we can have the criteria for transplantation can be upgraded or enhanced so that more and more number of patients can be taken up for these procedures. Now see why we are talking about transplantation. The difference between the transplantation and the dialysis, something has been alluded by the previous speaker also. If you look at the patient who's on dialysis, even if he's on adequate dialysis, 3 dialysis per week, he has to go to the hospital 3 times a week, and they are always complaining of something like fatigue, fluid overload, breathing difficulty, and they have to invest their time, they have to take their pills, phosphate binders, multiple pills are going on. On the contrary, if you see the life of a transplant patient, which is approximately close to the natural normal life, 2-time pills, few follow-ups with the doctors, and almost living with some kind of restrictions around. It's not a completely normal life, but it is fairly normal life which you are living. So that's why transplant, and if you look at the other things, it improves the life expectancy, it reduces the chances of cardiovascular events or the mortality, and improves the quality. Of course, the quality is definitely far, far superior, and Dr. Kher has just shown the cost differentials between the dialysis. About 3 years cost of dialysis is almost approximate to the cost of transplantation, and the maintenance of transplant is fairly meager as compared to good quality dialysis. Now this has already been referred. If you look at the survival facts of the patients who get a transplant versus the patients who are left on dialysis, you see the first line, if you see the annual mortality on a dialysis patient is to the tune of about 20 to 25%. While the annual mortality of liver-related transplant is only 4%, 5 times advantage of living better quality and longevity in a patients. And who is the most benefited? Invariably, it's a common question which comes to me when somebody refers me as a transplant patient with who's a diabetic. He asks, are you transplanting a diabetic patient? Look at the bottom of this particular line. I mean, just look at the bottom. The most advantageous fact comes in favor of a diabetic patient. If a diabetic goes on dialysis, his probable life survival is about 8 years. On the contrary, if he gets a transplant, it's 25 years. So yeah, that's to 25. And this benefit in an age group of 20 to 40 is probably the enormous. It's the maximum output which one can yield closest to the normal natural life. So most advantageous is to the diabetics, and most of the patients whom I'm transplanting, they are diabetics. Now, when I was in my training program, this is a list of large number of contraindications. These are the contraindications which were listed and handed over to us when we were trainings, that these are the patients which are not supposed to give them a transplantation. So these are the newer things which has evolved over the years. Number one is the blood group was complete. No, if it's no match or O group donor is not available, forget about the transplantations. But with the advent of ABO incompatible transplant, now this is the first Northern India's ABO incompatible transplant from Delhi, which was carried out between the two brothers. And since the advent of this 2012, we have been doing this kind of, we are running this program on a regular basis. Almost all the Delhi transplant centers from all the places, Delhi NCR, everybody is doing this ABO incompatible transplant. Now it's now a very regular routine. Now advantage of this kind of a transplantation is there is always an available 30% chance that you can include a donor who is available in the family, but because of blood group was earlier not offered the transplant donation option, which can be taken up. And our outcomes are almost similar. This is a very large study, about 1,800 patients, which has been published very recently. And if you look at the bottom line of this is the unmatched univariate analysis outcome between compatible ABO compatible or incompatible transplant, they are almost similar outcomes. So we are almost achieving the same kind of outcomes. Now this is our working group from nephrology, which has given us the guidelines for the ABO incompatible, which so it's almost pan-India level, which we are following a very specific kind of a systematic approach to these transplants, and outcomes are quite similar. Now this is the data which is published from Dr. K's unit, which they have shown 10-year graft survival and a patient survival, which is also pretty good and impressive data rather, I would say. Now another serious change which has come up was there was a patient who had an HLA antibodies. They were excluded from transplantation program, but since we have overcome, we have started having a better understanding about HLA typings as well as the antibody levels, and we've got a much advanced platforms to identify these antibodies and quantifications, so we can approach these patients, we can offer them a transplantation without any major hitch nowadays. Now if you look at about 10% patients earlier had some kind of HLA antibodies for various reasons like blood transfusions, prior transplantations, pregnancy, and quite significant numbers had no reason why they would have anti-HLA antibodies, maybe across reactivity with some kind of fungal, bacterial, or viral infection. So that was why these patients had developed HLA antibodies. Now, if you look at the HLAs, now there are two things which we need to look at is, when you're doing a quantified HLA parametric assessment of a given patient, like between donor and a recipient, now if the HLAs are matching, it would ensure the long-term longevity of the graft. The more the mismatch, less is the longevity. On the contrary, if somebody has anti-HLA antibody on an assessment right at the beginning, at the point of transplantation, unless you negate these anti-HLA antibodies, the outcome may be catastrophic in immediate transplant period. So you have to quantify these antibodies well in time. Now this is the slide which shows how the matches and mismatches are carried out. I'll just skip some part of it, but I'll just choose the outcome. This is the ANZ data, which if you look at the top survival and the lowest survival, 0 mismatch and 6 allograft, still 6 mismatches shows about 40% survival difference at the time of 10 years or more. Now this is a similar kind of data has been observed in another study which is in a pediatric population. So matching is important in terms of non-generation of anti-HLA antibody over long term and loss of a graft. Now, how do we identify if somebody has got a preformed antibodies which could immediately impact the transplant outcome? So these include CDC cross-match, augmented cross-matches, flow cytometric cross-match, Luminex. Now, there are the newer additions are like Luminex cross-match, anti-HLA antibody screenings, and anti-DSA lysate-based testing, which is a bit in question now, but it has come up with the newer techniques in this. Even this has gone to the next level of advancement. Then we do the virtual cross-matches. We do high-resolution HLA typing of the donor and check the antibodies through this Luminex methodologies, and it can quantify their MFIs against those particular antigens against which these antibodies are existing in a particular patient, and then offer them a transplantation or we can nullify these antibodies through various procedures which I'll allude to sometime in my next slides. Now, the basic test which we do is CDC cross-match or the augmented CDC cross-match, which has very high specificity and very low sensitivity in fact. But if somebody comes to me who's got a cross-match positivity, I'll have to think 100 times before offering him a transplant. On the contrary, if somebody comes with a DSA cross-match positivity, which has got a very high sensitivity, the antibody levels may not be very prudent, or it may not be specific to that particular donor. So I may be able to carry out the transplantation without much of the hitch or additions. Now, this is some of our own experience in transplantation, where we look for more specifically for pre-existing HLA antibodies is particularly when somebody is looking for a second transplant, third transplant, or the female particularly when the donor option is coming from husband or the children or the in-laws family. So there is a high probability that this lady has been probably some point of time during her pregnancy, if she is conceived, has been exposed to the antigens from the other family. So this kind of antibodies have to be identified and properly addressed before transplantation. If you don't address this antibodies, you probably may have issues immediately post-transplantation period. Now this is some of our data which we did in last 3 years, about 350 transplants we did, and out of these 350 we did about 400 plus cross matches. Our baseline CDC cross match positivity was only 1%. But when we started looking for anti-HLA antibody screening tests, it suddenly mounted to 4%. So there was inherent antibodies which could be missed by the conventional testing. So we have now superior tests which could identify these antibodies. And whenever you have identified antibodies, particularly beyond a particular level, I would not go into refer to those numbers because they are very specific ones. So there are ways to come out to bring down those antibodies with the help of these methodologies which we adapt in our patients and once we have brought down the antibody levels, we offer them mid-transplantation. So all in a nutshell, what we have to say is that there was a barrier which we have almost transgressed now, where we can offer the patients who are sensitized towards HLAs, we can offer them a transplant with a specific means which I've just alluded to. Now, very recently, in the last 5 years, I will just show you all the transplanters who are sitting here. If you look at this particular picture very carefully, many times when the clamps are released, you find the kidney starts becoming flaccid and it starts developing the bluish spots like this. That means there is a preformed antibody which has been missed by your testing, and the antibody has immediately got in action, and these kind of floppy kidneys were earlier thrown out. In fact, we used to dissect these kidneys, close the surgery and abandon the procedure and move out from the theater immediately. So this was the process which was carried out earlier. But in last 5 of our patients, we have moved in this is our paraphernalia of desensitization, which includes plasma exchanges on table in theater with large high-dose IVIGs. We could salvage 3 out of these 5 kidneys, we have these events in theater itself. So these are a few rare things which have started coming up now in transplantations as well. Now, something which Dr. Kher mentioned about a few minutes back about the malignancies. Now, see the malignancy. Post-malignancy to get a transplant is probably not a common thing which we see as an Indian physicians, because most of our patients don't have that kind of a survival ability, financial ability, or many reasons. But if you look at the global data, the data is now emerging that these patients, whenever if they had an end-stage disease, they have survived their malignancy first or a second for a particular period of span of time, which is otherwise eluded around 2 years. And since the advent of PET scans, we have come down to about 1 year time tenure. So if this patient is disease-free for more than 12 months, you can consider these patients for a transplantation. The reason for that being because if these patients are left on dialysis, their survival is about 25, the annual mortality is roughly about 20 to 25%, which we just talked about. Every 4th patient would die. On the contrary, if this patient gets transplant, if you look at this number, the lower bottom again, the recurrence rate of malignancy is only 2.4 per 100 patient years. On the contrary, the annual mortality is 25% for a patient. So it's much better that this patient is offered a transplant and is likely to have a better chance of survival if he gets a transplantation. These are the list of few malignancies which are seen in post-transplant period, and quite a few of these malignancies does not have a high recurrence rate even transplantation. There are very few of them. They are either specific to transplant or they have high rate of recurrence post-transplantation. This is some of our experience where we have transplanted post-malignancy patients, or we have encountered our malignancies, our set of issues in terms of malignancies in transplant patients. Now, active infections, I would just skip this because Dr. Kher has just given a very large overview around this. The infections are not uncommon, particularly the patient who comes to seek a transplantation. This is the data which we have put in here. Every 3rd patient of mine who is looking for a transplant is carrying some kind of infection during his pre-transplant assessment and treatment strategic planning. It may be simple bacteremia coming from the lines, or maybe something incipient tuberculosis which needs identification and treatment. This is our data which we published after COVID period, and unfortunately, we had a very high mortality in a post-transplant COVID patients, roughly to the tune of about 28%. We published for both first wave and second wave, and a concluding data also. And antibody transformation, somebody had asked the question in the previous talk. The seroconversion rate, which is again our own published data, is just about 42% of the post-transplant patients when we give. But this is just a recent past. I don't think it makes any relevance now. In coming times, as it looks, the COVID seems to be getting over now, or becoming a community prevalent disease which may not have any implications. So this is again a large data of published from the hyperactive transplanter centers which had been doing the transplantation during COVID period also, and they, according to them, the COVID didn't have much of impact on transplant selection, immediate outcomes. But I probably refrained during that period from offering any transplant to my patients. Now, another the area which has seen a sea change, that was considered a contraindication, was retroviral disease, but now there has been a well-balanced global data, and we have also experience of close to about 30 patients whom we have transplanted. Majority of them are black patients, but we have done a couple of Indian transplants, patients who had a retroviral positivity. There are selection criteria of CD4 counts, which is earlier it was about 6 months period, 2 counts which are negative, now it's about 3 months period, and if the viral load is negative, you can offer them a transplant, but there are certain caveats in terms of selection of antiretroviral drugs, which as a transplanters we are all aware about it. And the outcomes are quite similar in these patients as compared to the patients who are retroviral negative to treat with. Now coming to extrarenal diseases like pulmonary, cardiac or hepatic disorders, most of these patients, if they have a cardiac revascularization issue, so the PCIs or CABGs have been carried out, and we offer them a transplantation. Similarly, in pulmonary patients, unless somebody has got a cavitatory large lesion and which is non-resectable, we don't refuse the patients to go for a transplantation. Similarly, for hepatic dysfunction, we are fortunately, I was the first nephrologist to be involved in a first combined kidney liver transplantation in India. So we did our first way back in 1998, probably the first first combined kidney liver transplantation. Since then, this is a regular phenomena. Anybody who has liver disease leading to kidney disease or kidney disease and a liver disease simultaneously, they are offered SLKT, which is a regular treatment strategy, and which is offered at multiple centers now. Now, lower urinary tracts incorrectable diseases or the glomerular disorders has the recurrence rate, but fortunately with immunosuppressants which we are currently using and the kind of methodologies which we have to identify the recurrence of a disease with the biopsy admins and the biopsy reporting criteria, probably we can manage these patients much better. Now, there was another serious no to patients who had a psychiatric illness, but large psychiatric bodies have come up with a wonderful statement. It states to exclude patients with affective and psychotic disorder on the basis of their psychiatric diagnosis alone is unjust. So most of the patients who have any kind of, with the current armamentarium of antipsychotic drugs which we have, probably we can offer them good transplantation and good quality of life to these patients also. Another key area in a transplant which we see a change or which we see as a follow-up advent is non-compliance, which is pretty common. Fortunately, the drug, this is our own data, the non-drug compliance is less than 1%, drug non-compliance. But follow-up compliance is a serious issue. After the 5 years of transplantation, follow-up compliance is as low as about 70%. About 30% of patients do not turn up for their follow-ups to the respective physicians. This is not uncommon unless they have got another issue which is cropping up because of the transplantation. Then only they start reviving their contact with their physicians. Otherwise, 25 to 30% patients. But I would say the non-compliance is a normal, natural human behavior, so it is not uncommon to see such issues with these patients. Now, morbid obesity had been at one point of time known with the advent of the robotic surgery, which is, Delhi is in fact a mecca of this surgery. Medanta started first, it's happening at Max, Dr. Kuller's station. Unfortunately, my hospital has yet not adopted this strategy, but this is a wonderful, for the patients who are obese, or those who had incisional issues, they can be offered transplantations now. Ours is a country which we call as a young country, but still we have about 5% population, one must not forget, which is above the age of 60 years. So they also have to be benefited by their transplantations. Elderly survival on transplantation is still better than they being left on dialysis. So it is better if they have an option of a donation or a cadaver option can be offered to them. One should not exclude these patients, and these patients should be given a transplantations. And then rare diseases like primary oxalosis, coagulation disorders, there are very competent recombinant therapies are available, and in oxalosis we give them a combined kidney liver transplantation. That's how we have evolved ourselves in the treatment strategy in these patients. And now this is the latest which has come up now. The xenotransplantation. Unfortunately, the 3 transplants which has happened in last 6 months, 2 of them died in 2 months. The final detailings are still not available because the histopathological diagnosis, organ dysfunction disorders are being carried out. This man lived for close to about 2 months. And this is the team which did it at Massachusetts. And let's see. I'm quite sure we are very close to this kind of a transplantation to come with. And I'm quite convinced that one day my clinic would be on the left side. So pigs would be coming to nephrologists to say them hello. Every patient would come with their own donor, which may not be a relative. It may be a pig which has been genetically edited for him. The previous one which I had talked about, this pig was edited at 69 genomic genes were edited for him to make it compatible. I think with this I'll stop my talk. This is my recent visit to Lalit. Thank you very much.
Thank you, sir, for an excellent presentation. Just for our nephrologists, and since there are majority of physicians here, I don't think xenotransplantation would be possible in India even in next 2-3 decades, because there may be ethical issues related to that. You need genetically modified pigs. And as you showed your data, these all patients were really sick end-stage patients, advanced age, or something. And what you showed in your data, 20 to 39, maximum population which we see in our clinic, am I going to offer him a xenotransplantation? Still I don't know which is going to survive how long. So for me, xenotransplantation is there. But for recent updates, I think 2 or 3 things have come up. There may be transplant tolerance, which we might be talking in future. And again is rejection detection. Allograft rejection detection, which is a newer thing right now in India.
Yeah, I agree, Dr. Lalit. There are new armamentarium which we have for rejection detection, which Dr. Satish has already alluded to, so that's why I've missed on that. But I think, yeah, you're absolutely right. Yes, I agree. Xenotransplantation, it's still yet have to evolve long way. We've been reading about it for the last 3 decades. There was a question when I appeared 27 years back for my national program, xenotransplantation. At that time, questions were, one small note was asked, and it's 30 years. We are still nowhere close to that.
Yes,
I agree. I fully agree.
Any questions, or we can? So we can conclude the session, sir. Thank you, sir.
Thank you very much.